Good morning. It's my pleasure today to chair this symposium for the IAGG meeting. The symposium is called Translational Research to Optimise Outcomes from Medicines in Older People, Early Career Researcher Insights. My name is Sarah Helmer. I'm a geriatrician and clinical pharmacologist at Royal North Shore Hospital in Sydney, Australia, and a conjoint professor of geriatric pharmacology at the University of Sydney. Today, our presenters will be three of my Australian mentees in this field: Dr. Emily Reeve, Dr. Lisa Kalagin-O'Donnell, and Dr. John Mack. I lead an Ageing and Pharmacology laboratory at the Colling Institute, which is a joint venture between Northern Sydney Local Health District and the University of Sydney. This is a picture of the Colling Institute, and this bridge goes directly to our acute hospital, facilitating our translational research. My research group includes people who work in our basic science laboratory, people doing clinical studies, and people doing population health studies. Together, we bring together the fields of geriatric medicine, clinical pharmacology, and ageing biology to work out how best to use medicines to optimise ageing. Internationally, the current WHO patient safety challenge is actually medication without harm, and this challenge identifies polypharmacy and vulnerable populations, which includes frail older people, as key pillars of the intervention. In Australia, I led a report called Quality Use of Medicines to Optimise Ageing in Older Australians, recommendations for a national strategic action plan to reduce inappropriate polypharmacy. Here are some of the key facts and figures. 2 out of 3 Australians aged over 75 take 5 or more medicines. Approximately half of all older adults are taking a medicine that is harmful or unnecessary, and 9 out of 10 older adults are willing to stop a medicine if their doctor said it was possible. Clearly, as this field emerges and our population ages, it's really important to build capacity to meet the needs of the ageing population. Today, the 3 early career researchers who will be presenting are Dr. Emily Reeve, who is a pharmacist whose work is around patient-centred deprescribing and is the current chair of the Australian Deprescribing Network. Dr. Lisa Kalagin-O'Donnell, another postdoctoral pharmacist whose work is in clinical decision support in medication management. And Dr. John Mack, a basic pharmacologist who conducts bedside to bench research in my lab at the Colling to understand polypharmacy and deprescribing. I hope you enjoy the symposium. Thank you.
Today I'm going to be talking about 2 projects which involved engaging with consumers and clinicians to drive research into optimising medicine use. To begin with, I would like to acknowledge and pay my respects to the Wurundjeri people, the traditional custodians whose ancestral lands I'm presenting from today here in Australia. The first project was the top 10 unanswered questions about medicines in people living with dementia. This project was done by a research team from across Australia. We also have had a stakeholder steering group, which involved a number of consumers as well as clinicians, and they were involved throughout every step of the project, and a number of partner organisations such as professional and consumer organisations. And just want to recognise our funders of the Australian Association of Gerontology and Dementia Australia. So currently about 50 million people worldwide are living with dementia, and this number is set to increase. In Australia, about 500,000 people are living with dementia, and this also involves about 1.5 million Australians involved in their care. Now, dementia is associated with ageing, so we see that people living with dementia commonly have a number of other medical conditions, and because of this, we see that people living with dementia commonly take multiple medications. So about half of people living with dementia have polypharmacy or 5 or more medications. And we also see that medication use may not be appropriate. About 60% may be taking a medicine where the harms outweigh the benefits in the individual. So that brings us to this concept of quality use of medicines, which means using medicine safely and effectively and selecting the best treatment for the individual to obtain optimal health outcomes. It also means only using medicines when they are needed and stopping medicines when they're no longer needed. But achieving quality use of medicines in people living with dementia is complex. So some reasons for this is that we see this population is often excluded from clinical drug trials as well as health services research, but there are pharmacokinetic and pharmacodynamic changes that can occur which influence the benefits as well as the harms of medicines. And then in terms of delivering healthcare, there are some complications due to difficulties in establishing goals of care and the fact that goals of care are going to be continuously changing, as well as things like recognizing and reporting adverse drug reactions and fragmentation in care. What all of this adds up to is an impact on the individual, so burden in time, effort, and cost, as well as the clinical consequences of adverse drug events. This then has an impact on the healthcare system, so the cost of treating those consequences, as well as the cost of medicines, which really means that money is being used on things that are called low value or no value healthcare, and this money could be better spent on other medicines or even other service provision. But just because achieving quality use of medicines in people living with dementia is complex, it doesn't mean that it's impossible, but it just highlights, in fact, that this is an under-researched area and there are gaps that could be researched to inform better care. But you might wonder, where do we start when we know that there are quite a lot of complexities here? Traditionally, commercial entities like pharmaceutical companies or researchers or sometimes funding agencies are the ones that drive the research agenda. And historically, there's been limited involvement of consumers and clinicians in deciding what research should be conducted. But if we did involve them, this would help ensuring that research answers the questions that are actually being encountered in practice, which would mean efficient use of research funding and reducing the evidence to practice gap, which essentially means that we can get research adopted or implemented into practice a lot quicker. So that led to this project. And so we're really looking at what are the top 10 research priorities as determined by people living with dementia, their carers, family and friends, and healthcare professionals. I'm going to go over the methods quite quickly. They are established methods by the James Lind Alliance and have been used internationally for a number of different medical conditions and different topics. So first we formed our priority setting partnership, which involved that research team, steering group, partner organisations, and our advisor. We then did a first national survey, which asked, what questions do you have about medicine use in people living with dementia? We ended up with over 500 questions submitted from over 200 consumers and healthcare professionals. We then used qualitative analysis to group and summarise the responses that we got to lead to 68 summary questions. And just to give an example of what this looked like is we got quotes like, how can I make it easier for my mother to remember to take her medicine? Or how can I avoid transfer to residential care simply for reasons of medication mismanagement? We took those quotes and we've created the summary question, how can people living with dementia and their carers be supported to manage medicine safely at home? Another example was quotes of, do his medicines lessen his anxiety, or is there an antidepressant that's preferred for use in dementia patients? And we created the summary question, when, how, and in who should medicines be used to treat depression and anxiety in people living with dementia? The next thing we did is called evidence checking, and we wanted to make sure that these questions hadn't already been answered by research. After this, we ended up with 67 unanswered research questions. This then led into a second national survey, again, where we asked consumers and healthcare professionals to pick from the 67 unanswered questions to determine what our top 16 unanswered questions were. These then fed into a final workshop, which we conducted with consumers and healthcare professionals, where they worked together to rank and determine the top 10 unanswered questions. So here are the top 10 unanswered questions. The first one is, how can shared decision-making about medicines be achieved between healthcare professionals and people living with dementia and their carers? The remaining 10 are around, how do we ensure healthcare professionals have the necessary knowledge and skills? How can communication between healthcare professionals be optimized? How can we achieve deep prescribing, managing pain, managing medicine safely at home, treating changed behaviours, residential aged care facilities, treating depression and anxiety, as well as what the optimal model for medicine reviews are. So if we can direct future research to these priorities, we can make sure that the right research is being done, so it's answering the questions that are being encountered in practice, which means it has the greatest potential for impact and the greatest potential to be implemented into practice quickly, which means that there is potential for direct impact in improving the care and lives of people living with dementia. The next project I'll talk very briefly about actually did start to answer one of these questions around deprescribing, which was exploring the willingness of people with dementia and mild cognitive impairment to deprescribe. Just quickly recognizing the team and this bigger project that this was involved with was funded by the National Institute on Aging in the US. So when we first started exploring barriers to deprescribing and we spoke to healthcare professionals, we heard from them that the patients and their family members are a major barrier to deprescribing. But then when we actually spoke to older adults, they were quite open to it, but recognizing things like they would need to have a discussion about it. That led us many years ago to develop the Patients' Attitudes Towards Deprescribing questionnaire, which is to be able to quantitatively capture attitudes as well as explore different associations. We recently did a systematic review of studies that had used the PATD and the newer versions, which includes the rPATD COG, which is a version for people with cognitive impairment. We found 40 studies, and in our meta-analysis, we found 84% of patients and 80% of caregivers are willing to have a medication deprescribed. But we realized only one study had used the rPATD COG, which was a study we'd done earlier, and it had quite a small sample size and was only done at a single site. The other thing we found from this systematic review is that there was a large inconsistency about whether different participant characteristics are associated with willingness to have a medication deprescribed or not. So the aims of this study was to determine the attitudes of people living with cognitive impairment towards medications and deprescribing, and to explore some of the associations and relationships between participant characteristics, including medication use, and their reported attitudes and beliefs. This was achieved as part of a larger study, the OPTIMIZE study, which was a pragmatic trial to optimize deprescribing in older adults with dementia. And the rPATD COG was distributed to intervention patients at baseline. It was included older adults who had at least one other chronic condition and were on 5 or more regular medications. We ended up getting responses from over 500 of our intervention participants, which was a response rate of about 40%. So we found that similar to previous findings, 78.5% of our participants said that they would be willing to have one or more of their medicines stopped if their doctor said it was possible. But you'll also see quite a high agreement with satisfaction with their medicines as well. When we looked at what characteristics may be associated with willingness to deprescribe, I've just got a few of them on the slide here, but essentially we only found one characteristics, which was number of chronic conditions was associated with willingness to deprescribe. So then we looked a little bit deeper and we looked at whether the number of medications was associated with some of these other beliefs. And we found, not surprisingly, perhaps, that those who were on more medicines were more likely to think that they were taking too many medicines. But we also found that those who reported having a bad experience in the past when stopping a medicine were on more medicines than those who hadn't. Then when we looked at inappropriate medication use, we found similarly, those who are on an inappropriate medication were more likely to have had a bad experience in the past. And we also found that they were more likely to report getting stressed when changes are made to their medicines. So in conclusion, we found a high level of willingness to deprescribe among people with dementia and mild cognitive impairment, which is similar to populations without dementia. But we weren't really able to find any external characteristics other than number of medical conditions that were associated with willingness to deprescribe, which may mean that to inform research and practice, that actually directly collecting the attitude, such as through use of the rPATD COG, could be a way to target interventions as well as drive education. We also identify some potential key points that could be used in educational interventions and one-on-one conversations are to address previous bad experiences with deprescribing, as well as potential stress that people feel when changes are made to their medicines. So thank you for listening to my presentation.
Hello, my name is Dr. Lisa Collagen-O'Donnell, and I'm a research fellow in geriatric pharmacotherapy based in the Colling Institute, Royal North Shore Hospital and the University of Sydney, Australia. Today, it is my pleasure to talk about the role of digital health to optimize medication management in older adults. To begin with some context, we have an increase in the aging population globally. With old age comes multiple chronic conditions for which you have to use multiple medications to treat. And polypharmacy causes an increase in medication-related harms and risks. Although there are many efforts to address this issue, we still see older people admitted to hospital with medication-related problems. In fact, a study that was published in January this year reviewed medication-related hospital admissions in Australia from 1988 to 2021 and found almost 2/3 of medication-related hospital admissions were potentially preventable. So I'd like to call this issue the geriatric pharmacotherapy mantra. However, we need to change this mantra to a more positive tone to reduce the risks and harms associated with taking multiple medications in older adults. To change this mantra, we need to have person-centered care. We need mechanisms to identify which medications may be inappropriate for older adults and to incorporate the patient's or carer's views into the deprescribing process. Digital health technologies can improve communication, collaboration, and the use of evidence-based guidelines, and these can overcome several identified barriers to healthy, independent aging. Digital health technologies range from smartwatches and telehealth to electronic prescriptions and self-controlled electronic health record. However, my research focus for the last decade has been the development, validation, and implementation of computerized clinical decision support systems, or CCDSS, into primary care. CCDSSs are defined as multiple integrated systems that can apply algorithms to individual patient data to generate suggested actions intended to improve or support clinical decision-making for healthcare practitioners. These range from simple pop-up alerts within electronic systems that can identify serious drug alerts, allergies, or interactions, all the way to sophisticated tools incorporating clinical prediction rules to prompt clinicians to deliver evidence-based care, optimize drug orders, and improve documentation. CCDSS have been shown to achieve small to moderate improvements in care and a systematic review in 2019 of inappropriate medication. Knowing the benefits and potential of CCDSS to tackle polypharmacy, we set out to develop and validate GMEDS, the Goal-Directed Medication Review Electronic Decision Support System. GMEDS provides guidance for healthcare practitioners conducting medication reviews and to tailor care to meet their patients' goals and preferences. GMEDS consists of the Goals of Care Management Tool, the Drug Burden Index Calculator, and the revised patient attitudes towards deprescribing questionnaire. The Goals of Care Management Tool allows healthcare practitioners to document their patients' goals of care. The Drug Burden Index Calculator is based on the extensively validated pharmacological measure of a patient's anticholinergic and sedative medication burden and provides a report to healthcare practitioners about the risks of these medications on a patient's cognitive and physical function. The RPATD questionnaire allows practitioners to understand the attitudes and the perceptions of their patients on stopping a medication. The development of GMEDs has been a work in progress. It started in 2007 with Professor Sarah Hilmer's creation of the Drug Burden Index, a tool that measures the cumulative burden of anticholinergic and sedative medications. The research continued with validation studies, some led by Associate Professor Daniela Ganitic, and the development of the DBI calculator as part of my doctoral work. With funding from the Australian government, we developed, validated, and implemented GMEDs into the primary care setting. I'm also currently involved with the implementation of the DBI calculator in the tertiary setting, in another study supported by funding from the Australian government. However, I'll be talking to you about the primary care setting study. In the primary care setting, I led a cluster randomized clinical trial of GMEDs within the home medicine review setting. So home medicine review is a medication review service that's government funded that can be conducted by an accredited pharmacist with referral from a patient's GP. We implemented the GMEDs as part of the intervention for the HMR provided by the accredited pharmacist. Although we found that the implementation of GMEDs did not reduce DBI at 3 months, we found that the pharmacists within the intervention group had increased the number of recommendations on medications affected by DBI. So there was clearly a gap between the pharmacist providing a recommendation and for deprescribing of the inappropriately prescribed anticholinergic or sedative medications. And this was puzzling. So given our clinical trial didn't achieve its primary outcome, I was curious to see what the evidence was to suggest whether CCDSSs can improve deprescribing of inappropriate medications. And I came across 4 systematic reviews. Most of the studies, or most of the reviews, concluded that CCDSSs reduce potentially inappropriate medications, and one study was inconclusive about the effect of CCDSS interventions on unplanned hospitalizations. So clearly there was some evidence. Studies conducted in the last 2 years, however, including our cluster randomized clinical trial, have also not achieved their primary outcome. For example, the MedSafer and the Senator studies conducted in Canada and Ireland, respectively, focused on adverse drug events and found no difference with the CCDSS intervention versus the control groups. The European PRIMA EDS tool was not associated with unplanned hospitalization or death. And similarly to our study in Australia, the Best Practice Alert study from the US found no difference in the number or proportion of patients using anticholinergic medication. So again, confusing on conflicting evidence that is coming across with CCDSS interventions in deprescribing inappropriate medications. So given the conflicting results with the previously conducted systematic reviews and the results of the newer studies using the CCDSS intervention, we are currently conducting a systematic review of the effectiveness of CCDSS on interventions on deprescription, and I encourage you to visit and engage with our work. During our cluster randomized clinical trial, we're also able to conduct a process evaluation to determine the utility of GMEDs within the medication review setting. We concluded that GMEDs demonstrates good utility to assist accredited clinical pharmacists to identify and assess anticholinergic and sedative medications during medication review. However, the tools within GMEDS, so the goals, the DBI and the RPATD, needed refinement for translation of the tool into practice. So we further refined GMEDS, and we are currently conducting a national rollout of GMEDS in practice. Given the barriers to deprescribing we identified in our cluster randomized clinical trial, perhaps we were targeting the wrong setting or the wrong population. So we hypothesized that a national rollout of GMEDS in practice can identify the cohorts and the settings where GMEDS can potentially be used. Therefore, this study aims to describe the users of GMEDS, the clinical settings where GMEDS was used, and the patients for whom GMEDS was used during a national implementation study. This study is still ongoing, and we have over 300 pharmacists, general practitioners, and nurses throughout Australia using GMEDS within their clinical settings. We will finalise this study at the end of the year, and we'll present these results in future conferences and publish our results in future papers. So in conclusion, CCDSSs may be a solution to polypharmacy in older adults. The development and validation and implementation of GMEDS within practice can lead to deprescribing anticholinergic and sedative medications in context of goals of care, highlighting that the need is, for patient-centered goals of care. And future studies will determine the role and implementation of GMEDS and other CCDSSs in practice. So the outcomes of our systematic review and the outcomes of our national rollout implementation study. So thank you for listening to my talk. I'd like to take this time to acknowledge my colleagues, of which there are too many to mention. My supervisor and mentor, Professor Sarah Hilmer. I'd like to acknowledge our funding, the Rothwell Fellowship in Geriatric Pharmacotherapy and the Penny Aging Research Institute. Our initial funding from the Australian Government, delivered through the NHMRC to fund GMEDS, the Aging and Pharmacology Laboratory, the Colling Institute, the Faculty of Medicine and Health, and the University of Sydney in Australia. If you'd like to visit GMEDS, feel free to click on the QR code that you can see on your screen. Thank you.
Well, I would like to thank the organisers as well as Chair for this opportunity and other speakers in the symposium for this opportunity to present today. So I'll be talking about bench-side research to optimise outcomes for medication use in older people. So basically, I'll be talking about what I've been working on as an early career and mid-career researcher. And I've basically been developing and using preclinical models to understand the effects of medication use on geriatric outcomes in old age. Brief introduction: medicines are used to treat morbidities. As we age, there is greater amounts of multimorbidity, which results in more medication use. So polypharmacy, the use of 5 or more medications. What do we actually know about polypharmacy? So we know the observational data on associations between polypharmacy and adverse outcomes in older age. So there's association. We also know that there is minimal evidence of safety or effectiveness of taking multiple medications, especially in multimorbidity. And finally, there's limited evidence on the clinical outcomes of deprescribing. So deprescribing is the planned process of stopping medications that may no longer be beneficial or may be causing harm, obviously with clinical guidance. But there are other things that we don't know we know might cause variability to response to polypharmacy, such as patient factors, age, sex, disease, and frailty, as well as drug factors such as the number, the type, the dose, and also drug interactions. But if you wanted to know more about polypharmacy, what about groups, or is there a way to measure high risk medications? And so Sarah developed a drug burden index, which measures sedatives and anticholinergics. In brief, this has been evaluated internationally, and we know that the drug burden index is associated with impaired physical function, falls, frailty, hospitalization, as well as mortality. So we know that there is association with polypharmacy as well as the drug burden index, but how can we take this further, and what don't we actually know? And so there are outstanding clinical questions such as are the associations between chronic medication use and adverse geriatric outcomes causative? Is the number of drugs of the type and dose of drugs that cause adverse outcomes? And are these effects reversible with deprescribing? So as I mentioned earlier, as an early career, I try to be bench-side techniques to understand and work this out. So I use mouse models to understand polypharmacy, and in brief, I basically give mice medications and then therapeutic medications and look at outcomes. And we look at the number, the type, DBI. Could it be what happens when you're taking monotherapy in polypharmacy, and obviously does deprescribe benefit? So in the first project we'll talk about is a chronic study where we administer medication at 12 months. So this is an age that represents middle age to 60 old, which is old age. So the drug interventions we looked at are here. So 3 different groups of polypharmacy. The medications in brief are commonly taken by older people. In the polypharmacy low DBI, we administered citalopram, which has a drug burden index, and in the high DBI we included oxybutynin, oxycodone, and citalopram, which have a higher DBI. We then also looked at, so I do apologize again that the metoprolol was missing, which is navy blue. We also did look at monotherapies, so oxycodone, oxybutynin, citalopram, simvastatin, and metoprolol, which are part of the high DBI regimen. So at 21 months, we continued, half of them continued treatment, another half deprescribed. And this is a age group that will represent old age. Now we measured outcomes at every 3 months. So we looked at well-being measurements such as frailty and nesting, activities of daily living, looked at gait, we looked at grip strength. For the interest of this study, because this talk, because I don't have in limited time, I'll be talking mainly about frailty and nesting. So what do we find when we looked at nesting? So I mentioned earlier, this is a measure of activities of daily living. We work every day, a mouse will build a nest every day, and they sleep in it. And so we provided nesting material, and then we measured the nest, scored the nest. So essentially, if they built a really nice nest, they'll score a nice score. If they built a terrible nest, they'll have a low score. As you can see here, following the same color codes as earlier, control is in white, 0 DBI is in green, low is in blue, and then high is in red, and the deprescribe is a dotted line. As you can see here, the high DBI or increasing DBI resulted in a poorer nesting score, and interestingly, we were able to reverse it with deprescribing. So these results are interesting because they indicate that DBI has effect. It's not really the number of drugs, and we can reverse it with deprescribing. But polypharmacy and frailty have always been an interesting factor. Is it polypharmacy that causes frailty, and frailty causes polypharmacy? Which direction is the causation? Does polypharmacy affect the different measures of frailty differently? And so we seek to investigate this. We use 2 different methods. So in the mouse, we can use the clinical frailty index, looks at 31 different parameters in multiple systems in the mouse, or we can look at the phenotype assessment and look at functional assessments listed below. For the test, first one, we looked at the clinical frailty index, and we find that with high DBI polypharmacy, so in the red line, there's a significant increase, as well as in the monotherapy citalopram. But importantly, when we deprescribe, only the high DBI animals were able to be reversed, as you can see here. When we looked at the different treatment groups, so treatments are listed on the top, and we looked at the clinical outcomes, the different deficits in the 31 for the clinical frailty index. As you can see here, the more red it is, the more stronger the outcome scored, lighter it is, less. And the idea that I wanted you to see here is basically each treatment caused different deficits. We also then looked at different frailty measures. So this is odds of being frail, which is a slightly different measure, statistical method with the one we used earlier. In the clinical frailty index, we only find the high DBI now being significant with the odds of being frail. But when we look at the modified frailty phenotype assessment, we find that higher DBI, so high, low, as well as modifiers citalopram, increase the odds of being frail. Excuse me. And to then take this further, we collaborated with some of our collaborators to sort of find out whether or not using proven prediction biological clocks, so the FRAID, which predicts lifespan, and also the FRIGHT, which predicts biological clock, biological age, using the frailty indices. We wanted to see whether or not this affected treatment effect, if there was a treatment effect. And from our study, what we do find is that treatment did not affect the lifespan as well as a biological age based on these two clocks. But what else can we do? And so we wanted to take this model further, and we looked at age and also sex, and we looked at the high drug burden index polypharmacy. So we've been very fortunate to be able to publish 2 individual papers, one looking at multiple different outcomes, another one applying a measure to look at 23 hours activity. And I'll go over that in more detail. So briefly in the methodology, we had male and female mice. Young animals were around 3 months, which is a young adult. Old animals were around 22 months, which is representative of old age. And then we applied 6 weeks of treatment, and we measured outcomes before and after, which I'll talk about in more detail. In the control animals, they weren't given treatment. In the high DBA polypharmacy, will provide the same regimen that was used in the chronic study. So what did we find? We found that high DBI polypharmacy impaired function. So if you look at this, the figures on the right, you'll find that they have control and polypharmacy back to back, and then you'll have young males, young females, old males, and old females. Black dots represent the polypharmacy, the white dots represent the control, and you basically find that with polypharmacy treatments, there's a reduction in grip strength, rate of rod latency, gait speed, total distance traveled in open field, which is a measure of locomotor, mid-zone distance percentage, which is anxiety, and also in nesting, so polypharmacy impaired function. When we look at it further and look at whether or not there's an age interaction, age treatment interaction, we find that nesting score, which is a measure of activities of daily living, as well as mid-zone distance percentage, polypharmacy significantly reduces a greater severity in old animals compared to young, as you can see here. So nesting score, they both produce the poorer nest, as well as being less in the mid-zone would indicate they're more anxious. We then looked at sex and whether or not there was an interaction or treatment, and we find that males had a greater decline in falling grip strength than females. So there's sex differences. We further then looked at, as I mentioned earlier, the laboras, which is a home-like cage. Basically, placed the animal in it, and we looked at what happened over 23 hours. And as you can see here in brief, males are controls in the black line for both females. So males had the circle, females had the triangle, and then the red is a high DBI, again following circle is the male and triangle is the females. Take-home message here, so in the bright white section is when the animals are awake. Usually during this period they'll go to sleep. So we find out with high DBI polypharmacy there is actually less activity. But in the dark phase, when animals are meant to be more awake, knowing that we've gone home, they're more active, we find that high DBI does increase the activity. But it's very interesting, particularly at the end time point, which is the time when they should be going back to sleep. We find that they stay awake, and I'll talk about that more in detail in the next slide. So in the summary, what we found was that the preclinical models demonstrate functional impairment for high DBI for both ages and sexes. For most deficits, old mice were affected more than young, polypharmacy treated males showed greater reduction in grip strength, whereas females had greater reduction in gait speed in climbing. And there was increased activity during the transition to inactive phase, seen particularly in old age, and is analogous to drug-induced delirium and sundowning seen in older adults. So future studies will explore this further. But what mechanism could explain these outcomes? So we looked at pharmacokinetic changes, and I actually developed a method where we can quantify drug serum levels to see whether or not they cause these. They might be able to explain the mechanism. And when we looked at it, we actually found no difference in serum drug levels in young animals, so young males and females, as well as old males and females. Basically, there was no indication of why they may have this outcome. So in future, we would like to conduct pharmacokinetic and pharmacodynamic modeling, which is currently in progress, and we would like to look at that in the chronic study, which had a larger data set. So finally, to conclude, I have been applying preclinical models of polypharmacy, and this can be used to answer clinical questions. We find in our study that the drug burden index, so not the number of drugs, because they're taking the same amount, causes functional impairment and frailty, which is reversible with deprescribing in old age, which is a great thing to see. We also find that different drug regimens have different effects on different frailty measures, either the clinical frailty index or the phenotype assessment. We also find that there is no increase in lifespan or biological age according to the Fright and Fright prediction clocks. And finally, older adults are more susceptible to the effects of polypharmacy, and different sexes have different susceptibility to different effects. When we tried to explore the mechanisms, we found that these differences were not clearly explained by differences in drug levels. So finally, I'd like to finish by thanking and acknowledging all the members of the Laboratory of Aging and Pharmacology, and all the great mentors and supervisors and collaborators that have enabled us to do all this great work, as well as the Jeff and Elaine Penny who have supported our research. So thank you. Thank you all for paying attention to my talk. And I look forward to taking questions.
Hello, everyone. Thank you very much for joining us for the symposium on translational research to optimise outcomes for medicines in older people, with early career insights from a range of early career scientists who I've had the privilege to mentor, who come from a range of different backgrounds. We now go to the live question and answer. We've introduced ourselves on video, so I won't do it again, but I will say that it's 12 minutes past 10 at night here in Sydney, Australia, where which is the time zone that we're presenting from, on a public holiday. So I'd like to start by thanking the dedication of the early career researchers who I have had the pleasure of hearing this evening. Please put any questions you have in the Q&A. I'll read out the first question, which I think either Emily or Lisa might be interested in answering. This is from Katrina Davis from the UK. Many medications are not treating morbidities, but are prescribed for prevention of future morbidity. How do these fit in your model of medications for older people? When do we stop preventing or advise people that they are unlikely to benefit? Or is more research into prediction models needed to answer this? Emily or Lisa, or both of you, would you like to give this one an answer?
I'll hand that over to Emily.
Oh yeah, I'm happy to comment. I mean, the question is a very good one, and I think you've kind of almost half answered it yourself, is that we do need a bit more research. But what I can say is, in terms of preventative medications, it is an individualized decision, thinking about when the likely harms outweigh the likely benefits. And when we're considering benefits, we may need to be considering what their remaining expected life expectancy is. There is ongoing work with a few medications. We know with statins, which are used for prevention in somebody who has an estimated 12 months left to live, that they can be safely deprescribed without any increase in harm. And there's ongoing work related to statins and antihypertensives and a few other medications. So there's still medications that we consider for deprescribing as part of a whole package of benefits versus harms and how they align with the priorities of the individual. But as you've maybe pointed out, they can be a little bit more complex than something like a symptomatic medication. Lisa, do you want to add anything to that?
Yeah, thanks, Emily. I think it's you've eloquently answered the question, but I think the only thing I would probably add is thinking about the goals of care of the patient. At different time points in their life, earlier age versus later age, their goals might change. They might have varying goals, and so we want to make sure that some of those medications that they're being prescribed match those goals, and so that the patient is happier and is living a more quality life. So that's the only thing I would probably add to that.
Yeah. And I mean, I guess as I was just going to add, as kind of John's work highlights as well, that, we may think about medications as individual medications, but really when we're seeing these patients, it is that cumulative burden of all the medications they're on. And, the benefits of one medication may actually, or the harms of one medication may be counter to one of those goals of care, or maybe causing another side effect. So, which, may need to lead to another medication or something like that. So they are still part of that picture of that whole kind of polypharmacy and medication related burden.
Thanks, Lisa and Emily. Now, while we're waiting for other questions from the audience, I'll continue a bit of, discussion from the panel. And I think one of the main aims of putting this symposium together was not only to showcase the excellent research that these three are doing, but also to show the importance of capacity building in this growing field and the different things that people from different disciplines can bring. And I'd like to ask each of the speakers to just talk about the different fields of research that you bring together to be able to better understand how we can improve medicine's use and outcomes in older people. So why don't we start with you, John, because you haven't had a chance to talk yet, and just talk to us about the research background that you had and how you came to the field of polypharmacy and how you've brought the two fields together.
Yeah, again, thank you everyone for this opportunity to present today. So I think I started from a medical science background. I've always had an interest in researching and always fascinated me to discover new things. But I've also always had an interest in researching for improving improving healthy aging and successful aging. Watch my parents get older, and I want to make sure that they have optimized medication use, and that's why I do it. So I think where the basic science sort of fits in is really just answering questions that we can't answer clinically. So in terms of trying to understand the mechanism, that's quite difficult to do in patients. There's a lot of confounding residues, and that's where we sort of work. And so one side of it's actually understanding the mechanisms. Can we create models that will now enable us to basically mimic how it would be in a patient, and then understand it, identify the mechanism behind it, and then use that in knowledge to then drive policy change as one form of evidence. Obviously, we aren't the answer to everything, so we work together. And that's sort of where I sort of fit into the picture.
Thanks very much, John. Lisa, do you want to talk about your background and how you've gained the research skills you need to be able to do the important work that you're doing?
Thanks, Sarah. My background originally stemmed from pharmacology, so basic sort of clinical pharmacology type of work. Then I did pharmacy, so I'm a pharmacist by background. And when I was practicing, when patients would come into the pharmacy with bulk loads of prescriptions to be, filled, I would ask myself, really, is this the best quality of life that they're actually having with the medicines that they're taking, with the combinations of medicines they're taking? Are they happy with it? Which sort of led me to the research where I was struggling as a pharmacist, saying, how can I identify which one's best for this particular patient? And so some of my work, which looked at developing the drug burden index calculator, helped to identify some of those high risk medications. And then some of the work that I'm looking at with GMEDS looks at the goals of care and trying to make sure that the goals of care for the patient and the carer are met with the medications that they're taking. And so some of the expertise I brought to that is pharmacy as well, and I'm sort of starting to dabble into digital health, which is an area which is ever expanding and I can't keep up with, but it is something I'm very interested in. And so those are the types of fields of research I've sort of pulled in for the work that I'm doing.
Thanks, Lisa. Emily?
Thanks, Sarah. So like Lisa, I'm a pharmacist by background, and similarly had that experience working in a hospital and just seeing these people come in on so many medications and working with the multidisciplinary team in the hospital. But, you know, the doctors and the nurses were also there kind of saying, there's a lot of medications here, what can we do? And I would get to talk to patients, and even that questionnaire that I mentioned in my studies, that kind of came about because people would always say to me, I rattle when I walk, or I've got my own pharmacy at home. So I kind of really became interested with that patient perspective, which of course then extends to carers and their family. And I think that then informed the research path that I've taken, which I've had the pleasure of working in a variety of different pharmacy and medical departments, as well as getting to a lot of multidisciplinary and interdisciplinary research. And as I highlighted in my talk, really starting to get some genuine partnership with consumers, as well as that multidisciplinary healthcare professional stakeholders, to be able to, sometimes it's even that taking that step back and going, okay, what is actually what's most needed here? Where can we be dedicating our time, as well as pushing fields like deprescribing forward through those collaborations with consumers and clinicians.
Thank you very much. So these three fabulous examples of early career researchers have brought in different backgrounds, acquired additional skills to their research, and have been able to tackle the problems from different angles. And what I really love about my research group is that, we have all of them working there together. And so we have a range of different methods coming in to try to tackle the same problem. I think that's how we're really going to make headway in this really complex area of optimizing polypharmacy. Now, we've got a question about another method here in the chat, which I know that a number of us have thought about. And John, I might let you lead off with this one. This is from Arango, Victoria. Do you know if any artificial intelligence ways to help with polypharmacy? John, do you want to start with this from I guess the basic viewpoint, and then I don't know if Lisa or Emily would like to talk about the more population based, or if you'd like me to.
Yeah,
John, over to you.
I think. Yeah, thank you. I think that's actually a really good question. We're really stepping into the future, and I've always felt like we underutilize the data that we have. And so we're actually trying to apply machine learning and artificial intelligence, looking at visual analysis of the recordings that we have with our models to document maybe gait changes, changes in their behavior. And I guess looking at our models, it may mean something different, but when you then associate it to a human activity, say building a bad nest, daily activities, or them slouching a lot, bad posture, which would then connect to a human function. And so with that level of information that we can gather from it, we can then identify what are these drugs actually doing to these models, and then is that the same in the patient, and then what's the mechanism that actually drives that, so then we can further our advances in research and how we should be better caring for our patients. So it's an area that we're stepping forward in, and hopefully we'll be able to deliver more information in the future.
Thank you, John. And I think the very complexity of polypharmacy and multimorbidity lends itself to artificial intelligence to start giving us some clues to how these multiple drugs are interacting with each other and with the individual. Lisa or Emily, did you want to comment on any of the population studies going on at the moment?
The only thing I would, would comment on about AI and polypharmacy is that it's, as you said, Sarah, it's a very complex thing, and we almost have to be mindful that, yes, we can build AI to sort of address certain polypharmacy issues, but we also have to be mindful that the person we're caring for is a patient with their own goals and their own expectations, and we just have to be very careful that the AI isn't really predicting or making things more machine-like when we don't actually want them to be more machine-like. We want them to be about the person that we're treating rather than, putting a number to them. So that's probably the only comment I would make about AI and polypharmacy.
Thanks, Lisa. I think that's a really important point. I think when it comes to clinical practice, then we absolutely need our clinical skills and to be talking to the individual patients. In my mind, I think AI has a really important role in trying to understand mechanism and in recognising patterns, particularly for those really complex things that we don't understand, sort of drug interactions beyond drug pairs. But I agree, clinical practice needs to be done with a very person-centred and directed method, which, is better done by a person than artificial intelligence. However much artificial intelligence can give us some clues as to why we're seeing what we're seeing. Now, I don't see any other questions, and we only have a couple more minutes. So I think what I would like to close with, and I'll get each of the speakers to comment on this, is that what really came out here was the different approaches to personalised medicine and the different techniques that we can use to try to give people the individual care they need so that they get the best outcomes from their medicines. So I was wondering if we could close with each of you just commenting for 15 seconds or so on how the different experimental methods that you've employed can help us achieve personalised medicines for older people. We'll go in reverse order this time. Emily?
Thanks, Sarah. I employ a lot of qualitative mixed methods, research, as well as a bit of guideline development. And I think the thing that I really enjoy about that qualitative and that mixed methods is getting that real in-depth understanding of maybe what the barriers are. And we're just starting to work towards using those same kind of methodologies to then inform implementation and development of interventions and thinking about sustainability, and even something as what does quality use of medicines mean to that person, and all of that, which probably hands Lisa.
It does.
Yeah. Some of the methods I also have used, and I'm mindful of time here, RCTs and feasibility studies are some of the methods we use. I guess those obviously build evidence with some of the interventions that we're implementing to reduce polypharmacy. But again, it's about getting the formula right.
Thank you.
John?
And John?
Yep. Keeping it short, understanding a mechanism enables us to improve our care for patients.
Agree, John, and particularly those differences you see with age and sex and frailty and different patterns of susceptibility. So I'll just close by thanking everybody for attending and thanking the future of our field. Thanks very much, everybody.